Hello, fellow educators. Thank you for joining me in the second in a series of short faculty development segments. These segments are designed to provide you with actionable information to use in your teaching. Because everyone is busy, each segment features only 5 points in 5 minutes. Thanks for watching. This segment will demystify evaluations and answer 5 questions you may have. How are the numbers used? Where did the questions come from? What numbers should I give? How can I make my input useful? Will the resident be angry with me for what I say? Let's take these questions one at a time. How are they used? Each question on the evaluation for your rotation is matched to one of the 22 sub-competencies that the ACGME believes a resident be independent in performing by graduation. Evaluations provide information about how the resident is progressing on the road to independent practice. For example, on a wards evaluation, one question asks, can the resident care for patients admitted with the most common problems seen on the general medical wards? As outlined by the ACGME, to care for these patients, the resident must elicit an accurate history, perform an appropriate physical exam, and collect and interpret pertinent data. This question is tied to the ACGME subcompetency, Patient Care 1, or PC1. Questions from many rotations will be matched to each of the subcompetencies. This allows a number of data points to help determine if the resident is on track. From all these data points, a score is generated. The score is compared to the average score for peers. This tells us if a resident is on track, needs some support, or is performing above the expected level. This is a mid-year evaluation for a resident for PC1. Questions from all evaluations tied to PC1 give an average score of 3.3, which is slightly below peers. With this information, we can dig deeper to see if the resident requires any additional support to be successful. Question 2. Where do the questions come from? You. We met with rotation representatives to create questions that asked if the educational goals for the rotation were being met. Then, 5 anchors were created that describe behaviors that match levels of achievement. Anchors 1 and 2 describe behaviors in need of further attention. Anchor 3 described competence, and anchors 4 and 5 describe behaviors beyond what is expected. For example, one ICU question asks if the resident is able to recognize when a patient has become critically ill and whether the resident takes appropriate steps to address the change in status. 5 anchors for these skills describe levels of competence. The descriptive anchors allow you to identify a level of competence that is objective rather than a general gestalt. Anchor 3, highlighted here, describes a resident who is on target for that skill. This leads us to question 3. What numbers should I be given? The short answer is 3. Most residents should be a 3. 3 is competent to practice a skill with minimal assistance. Some residents might not be there yet. If so, let us know. We can help get them there. Some residents might be exemplary, anchors 4 or 5, but remember, if you think they're a 5, they should be better than you. Do you really think that's true? Question 4, how can I make my input useful? First, don't overinflate. Just like an overinflated tire, overinflated ratings won't work well. The information you provide is only one of many pieces of information used to give a full picture. A single number, like a single puzzle piece, will help create the full picture, but in itself is not high stakes. Inflated numbers won't identify what needs to be worked on. Also, add comments. Your comments provide valuable information. If you say read more or a pleasure to work with, the resident is likely to feel confused or even worse, think you don't care enough to provide guidance. We know that's not true. A comment like this one lets the resident know what could be done better and why. Your rationale for the plan would benefit from more detail. For instance, you wrote chest pain, not cardiac, no further testing. It's important to describe why you think it is not cardiac to demonstrate careful consideration and keep a Monday morning quarterback from not questioning what you did. And our last question. Will the resident be angry with me for what I say? Unlikely. Residents want your input. Our residents' biggest complaint is that they don't get enough information about how they're doing. However, please remember, there should be no surprises. Evaluation should document information you have already shared with the resident. Thanks for watching, and thank you for the time and dedication you give to educating our residents. You are who make them successful.